Welcome to the ICU Management and Practice DigiConf, Sepsis in Critical Care. Our Editor-in-Chief, Professor Jean-Louis Vincent, will moderate the session. Our panellists include Marc Leone, Professor of Clinical Medicine, Marc Leone, Professor of Anesthesiology and Intensive Care Medicine, Andreas Edel, Consultant, Department of Anesthesiology and Intensive Care Medicine, and Vitaly Herasevich, Professor of Anesthesiology and Medicine. Let us now welcome the moderator for today's DigiConf, Professor Jean-Louis Vincent.
Hello, good to see you and to start this session on sepsis. I just realized that there are only men in this session. We will be criticized, but the last session was with several women in the panel. So the topic of sepsis is, of course, extremely important. And I think we have a very nice program today, and we will learn a lot during these presentations. As always, we will invite each participant to present a summary of what was written in ICU Management and Practice. And of course, I encourage everyone to look at the publications. And after the presentations, we will have some time for questions. So do not hesitate to enter your questions through the chat system. So I don't think we should have a longer introduction. I would prefer to keep time for discussions. And so indeed, I will invite our good friend, Marc Niederman from Cornell in New York, as you heard, who will discuss the antibiotic strategies, which are, of course, very, very important. Mike, welcome. We cannot hear you. You are on mute. Yeah. Okay.
Sorry. Can you hear me now?
Yep, very well.
All right, now I have to share my screen and we'll be all set. There we go. All righty, well, it's a pleasure to be here, and I think we're going to have a very interesting discussion. My focus will be in a brief introduction of the topic of sepsis and some of the key principles for management, and I think that'll lead nicely into some of the other speakers. I've listed here my financial disclosures, but I want to start with the classic triad that I think we're all familiar with that determines the outcome in many infectious diseases, including sepsis. And that is a balance between the patient, the organism, and the therapy. And if we have therapy to choose, which is going to be my focus, we of course have to consider the patient's comorbidities and risk factors for specific types of infections and severity of infection. And we have to consider the organism and the organism's virulence and the dominance in a particular environment. And all of this leads to an appropriate choice of antibiotics, which in turn affects outcome. In understanding the site of onset of sepsis, this study of over 2.2 million hospitalizations documented very nicely that community onset sepsis is far more common than hospital onset sepsis, yet hospital sepsis has a higher mortality than community onset sepsis. Dr. Vincent did a very important study, the EPIC-3 study, which is a surveillance study in 88 countries, over 15,000 ICU patients, a point prevalence study of sepsis on one day in multiple ICUs. 65% of all the patients in that study had one positive culture, and gram negatives were the most common organisms. Gram positives were present nearly half as frequently as gram negatives. Many had mixed infections, and while gram negatives were present in 67%, fungi were in 16%, and viruses in about 4%. Most common site of sepsis was respiratory tract infection, followed by abdominal infection, bloodstream infection, urinary and kidney infection, and skin and CNS infections were less common. Infection with certain multi-drug resistant pathogens, particularly vancomycin-resistant enterococcus, resistant Klebsiella, and carbapenem-resistant Acinetobacter were all associated with an independent risk of mortality compared to others. And this may relate particularly to the difficulties in treating these multi-drug resistant pathogens. Now, it's extremely important, I think we've known this for many years, how important it is to get appropriate and rapid therapy in patients with sepsis. Inappropriate therapy increases mortality, treatment failure, and length of stay. And in this meta-analysis of 114 studies, it was very clear with severe bacterial infection that mortality was particularly increased with delays in therapy. And delays in therapy and discordant therapy were much more likely if there were multi-drug resistant pathogens. And I think that this is in keeping with the EPIC-3 data, that if we have multi-drug resistant pathogens, particularly if we don't anticipate them, if we don't account for them in our initial empiric therapy, we will have a delay in the initiation of appropriate therapy, and that in turn is associated with increased mortality. And illustrated here from that study are the common pathogens that are frequently treated discordantly, and the frequency of discordant therapy was particularly common with organisms like Enterobacteriaceae and Enterococcus faecalis, and particularly with Stenotrophomonas. So these are organisms that we have to be alert to. We have to know our own local microbiology. We have to know if these organisms are prevalent in our community, in our ICU, and we have to account for them if they're present with initial empiric therapy. There's a lower mortality with appropriate therapy without delay. And in the Prospero study, this was particularly true with severe bacterial infection. 6 of the 37 studies in this analysis were in ICU patients. And if we look particularly at the impact of delays on mortality, we do not want to have delays. We want to favor early therapy. And that's particularly true for infections like pneumonia, for bacteremia, and particularly for those who are in the ICU. So the basic principle of antimicrobial therapy is to anticipate the likely etiologic pathogens, anticipate the site of infection, know your local microbiology, choose your therapy correctly, do it immediately, and as soon as possible will reduce mortality. When we look at sepsis delays in the emergency department, this study pointed out very nicely that there are 2 types of delays that can occur in the emergency department. There's a delay from triage to the administration of antibiotics, but that can be the time from recognition of the sepsis, from entry to recognition, and from recognition to therapy. And what was identified is that more than 1.5 hours of an administration delay and more than 6 hours in a recognition delay are associated with increased mortality. So again, it's extremely important to recognize and treat sepsis in severely ill patients as early as possible. In a review article that was published last year in Critical Care, we discussed the initial antimicrobial therapy of sepsis, and we highlighted some of the key factors in choosing the right and rapid therapy for patients with sepsis. And this requires a knowledge of local microbiology. You must know what the pathogens are in your ICU and what their susceptibility to antibiotics are. You need to consider the common sources of infection. We've talked about the lung, the abdomen, and certainly intravascular sepsis and urinary tract infection, all important sources to consider in patients who have clinical sepsis. We must know the common pathogens, again, gram-negatives more than gram-positives, but anticipate specifically multi-drug resistant pathogens by considering multi-drug resistance risk factors, particularly prolonged hospital stay and recent antibiotic therapy. And of course, we have to consider the severity of illness. Patients who are particularly severely ill need to be recognized and treated as rapidly as possible. And all of these are the underlying principles for choosing the appropriate antibiotic. Now, rather than go into very specific guidelines for choosing antibiotics, which I will not do in the brief time I have today, I want to summarize some key principles that are in our article about how you manage the antibiotic therapy of sepsis. Sepsis, again, mandates prompt antibiotic therapy and source control. And as we saw, bacteria are the most common cause of sepsis, but viruses and fungi can also be responsible, but again, not nearly as commonly as bacteria. And among the bacteria, we see that gram-negatives are more common than gram-positives, And multi-drug resistant pathogens have to be considered because they're associated with frequently incorrect therapy, delays in appropriate therapy, and in turn increased mortality. Use of initial appropriate therapy reduces mortality, length of stay, and again, the likelihood of multi-drug resistant pathogen infection has to be considered in the context of local microbiology, and we have to give therapy as rapidly as possible for patients in septic shock, but no later than 3 to 5 hours in patients with severe sepsis, regardless of whether they're in septic shock. Biomarkers can be useful in deciding when to stop antibiotic therapy, but they shouldn't be a determination about when to use antibiotic therapy, particularly in patients with clinical sepsis. Even with appropriate therapy, we have to consider pharmacokinetics. We have to use the right dose. We have to often use higher than normal doses in septic patients because many of them have augmented renal clearance that requires a higher than normal dose of antibiotic therapy. They can have alterations in cardiac output, volume of distribution, and we have to consider the penetration of the antibiotic to the site of infection. Empiric antibiotic therapy of septic patients with pneumonia should never be with a single agent, and we should choose based on risk factors for MDR pathogens. Generally, we use broad spectrum initial antibiotic therapy, but there's an obligation to de-escalate from the standpoint of antimicrobial stewardship so they don't overutilize and abuse antibiotics. And the most important risk factors to consider when choosing empiric therapy are not only, again, local microbiology, but as I mentioned, recent use of broad spectrum antibiotics anytime in the last 3 months, recent hospitalization for at least 5 days in the last 3 months, and a knowledge of prior colonization or infection, particularly by pathogens like MRSA or Pseudomonas. For complicated intra-abdominal infection, we have to recognize this is often a polymicrobial infection. It can involve gram-negatives, anaerobes, enterococci, and initial empiric therapy is often with a beta-lactam, beta-lactamase inhibitor combination or with a carbapenem. And in some patients, Candida has to be targeted, and we add coverage specifically for intra-abdominal fungal infection. But importantly, antibiotics are often not enough for abdominal infection. It's important to consider source control with percutaneous or surgical drainage of intra-abdominal abscess. For bacteremia, there's a syndromic approach based on whether or not we have a prior positive culture. And with rapid diagnostic methods, we're identifying the etiologic pathogen and even the antimicrobial susceptibility much more rapidly than in the past. And this may allow us to treat correctly more rapidly. And fungal infection finally does need to be considered. It accounts for about 5% of all sepsis, most commonly due to Candida, and it can often be predicted by the Candida prediction scores, epidemiologic data, microbiologic information, even fungal biomarkers like galactomannan and beta-D-glucan. And risk factors for fungal infection overlap with other etiologic causes of ICU sepsis. So often we're forced to do preemptive and empiric therapy with a variety of antifungal agents, echinocandins for Candida, but that may not even be the correct choice in all instances because increasingly we're having Candida resistance. So I've tried to very briefly highlight some of the considerations for therapy of sepsis, identifying the common pathogens, the common sources, the general approach to therapy. And we can come back to this later when we discuss some of the very specific antibiotic choices in patients with very specific causes of sepsis. So thank you for your attention, and we'll move on with our program.
Thank you very much, Mike. It's a nice overview. And of course, it's difficult to deal with all aspects of antibiotic therapy. Now, at the beginning of your presentation, you emphasized the importance of early and effective antibiotic therapy, but I'm always wondering, isn't it logical if we think that antibiotics work? If you had studies showing that you can give antibiotics early or late, it doesn't matter. You can give the right antibiotic or the inappropriate one, it doesn't matter. Well, then we would have serious questions about the effectiveness of our antibiotics, right?
You're correct. And again, appropriate therapy refers to early appropriate therapy, not early antibiotics of any type. You've got to choose the right antibiotic, the right pathogen, the right dose. But again, early is important if we do it correctly. If we don't do it correctly, early antibiotic with the wrong drug is not going to be beneficial.
Absolutely. And I'm pleased to let you know that we have now more than 300 people with us, coming from many different countries, and already some very nice comments in the chat box. And of course, we have a couple of questions which may be more specific that we will keep for later. And before we move on, since we speak about the early antibiotic administration, of course, we will have to also discuss the excessive use of antibiotics. We do not want to bombard patients with antibiotics too early when it may not be sepsis. But you were right to indicate that the more severe the situation, the earlier the antibiotic administration, the more important that is, of course.
Right, and I do think it's important to realize that there are multiple time points in which you can adjust antibiotics. And so clearly in a very severely ill patient where sepsis is suspected, early therapy is probably necessary. And if you find out in due course that it's not an infection, you can always de-escalate to more narrow or even stopping antibiotic therapy. So I think the biggest mistake would be to have suspected sepsis and not treat early, and choosing the most appropriate therapy that you can based on all the considerations we talked about, and then adjusting later.
Thank you. Thank you very much. Let's move on and welcome our good friend Marc Leone, professor of anesthesia and intensive care in Marseille. He will present his ABC of sepsis, or perhaps even better, his alphabet of sepsis. Marc, the floor is yours.
Thank you, Jean-Louis. So I'm going to screen my up. So I decided to show you my alphabet of sepsis. That's just an overview, and you can read the paper in the journal issue. That's just a personal view. Without any constraint. I like meta-analysis, I like systematic review, but sometimes we are a little bit tired about this, and we need to give you our personal view without any consensus. That's my choice. I don't know if it's the best choice, but I just go through the alphabet and gave for each letter my view in relation with sepsis. So we start with A and B, C, D, and so with E, and that's for me the first letter is antibiotics, and the talk of Marc Niederman was so excellent. I have nothing to add, and this is perfect. And just for antibiotics, which is really important, that they are the key in sepsis, but of course there is an overuse because not all patients treated for suspected sepsis have sepsis, and we know now, and there is some good data from Weill and collaborators showing that too broad spectrum, too large use of antibiotic, overuse of antibiotic lead to resistance emergence and lead to side effects. So be careful with antibiotics. We need them. They save the life of your patients. It should be administered early in the course of the disease, 1 hour, and very early in septic shock in the first 5 hours with sepsis. But the balance between an overuse and the wise use of them is particularly important. So I will go very fast on B. B for me is, there is a lot of letter, but breathing is probably important and probably should be viewed with more attention, especially in the ward patient, in which the monitoring of breathing can be important. But I don't stay on that. So C is circulation. Circulation is really the cornerstone differentiating sepsis and septic shock. And as you all know, the definition of septic shock is sepsis associated with a vascular failure. So circulation is very important. And if you don't understand very well the principle of circulation in physiology and in all patients, you cannot treat adequately your patient. So circulation is especially important if you want to treat patients with sepsis and septic shock. And we should also keep in mind that microcirculation is probably impaired in most patients with sepsis before septic shock occurs. So for D, I will use dysfunction, but I could speak about de-escalation because that was my first topic in my professional life. But dysfunction, once again, is included in the definition of septic shock and sepsis. And dysfunction is really something important for the intensivist. We should look at that in our patient. We should look at that from a systematic fashion, using perhaps checklists or something like this. But every day we should detect dysfunction of organs in our patient. However, I don't like the principle of multiple organ dysfunction syndrome as cause of death, because for me it's not a cause of death, but a kind of picture of death. And under the multiple organ dysfunction, there is all the time a disease that we need to identify. E is early. We already talked about early in the previous talk. Early is very important in sepsis. The early identification, the early diagnosis of sepsis is critical for the outcome of patients. The early administration of antibiotics and also the early source control, that's really important in terms of outcome. And there is different score like the QSOFA or strategy using a point of care ultrasound, for example, that can facilitate an early diagnosis at the bedside, but really early should be kept in mind. However, the word early is really very often used, but in my practice, I prefer as soon as possible. And when I have patients with sepsis, I give the antibiotics as soon as possible, and I correct the organ dysfunction as soon as possible, not in 1 hour, not in 3 hours, as soon as possible is really important. F, I use F for fever. And fever is really a challenge in my professional life when I run in the ICU. Fever is really the attractive sign for resident. And if patient has no fever, he has no sepsis, and a patient with fever has sepsis. And in practice, it's wrong. It's wrong in 50% of cases. And so fever is probably overview in the medical world. We should keep in mind that patients with hypothermia, for example, may have worse outcomes than patients with fever. And finally, we don't know if we need to treat fever in the non-brain injured patient in ICU. And the experimental data favor not to treat fever if there is no brain injury. So fever is critical symptoms, but this sign can lead to treatment in excess, and we should be really more prudent, more careful with this clinical sign. G for gas exchange. Gas exchange is really important.
Mark, I'm a little concerned about the time, you know, because we are only at G and you are approaching the end of your summary here.
Accelerate, no problem. So G, H for hydrocortisone, which is still a controversial issue in septic shock. I for intra-abdominal infection, and I think we miss a lot of patients with intra-abdominal infection, and very often we are delayed in our management of these patients. G as junior, which I think that the education of junior about sepsis is critical. It's critical. K for kidney, because acute kidney injury is really a strong predictor of long-term outcome in these patients. And for lactate, lactate is really a wonderful biomarker for patients. There is some wrong positive, some false positive, some false negative, but most of the time it's really a very relevant biomarker. And all-in-one serum lactate should be remeasured in the slab test due in clinical practice. And for monitoring, it's important to use a continuous monitoring of cardiac output, even if it's under debate. For me, that's my personal view. And for nitric oxide, which is the mediator responsible for vasodilation, and that's really important to know this mediator, to understand the principle of vasodilation in our patient. Or for oxygen, and we all know how oxygen is important in patients with shock and those with septic shock especially. And it's important to keep in mind that elevated values of oxygen as well as oxygen central venous saturation or PaO2 are associated with impaired outcomes. So we need to balance the benefit and the harm of oxygen in our patients. P for pneumonia. Pneumonia is really important. It's the first cause of infection in ICU. It's framed by guidelines, but I really think that in clinical practice, there is an overdiagnosis of pneumonia, and sometimes that can result in mistake and in wrong treatment and in delay in the management of other infections. So be careful. Pneumonia is very challenging as diagnosis, and try to keep it as last diagnostic after eliminating other source of infection. Q for Q so far. I don't know what you think about that was a good idea. In practice, I don't feel it's really useful at the bedside in most wards and in emergency department. I don't know, but I don't use a lot in clinical practice, and perhaps that has been a little bit disappointing. For relatives, that should be considered in patients with sepsis, because it's difficult syndrome to understand, and a good communication requires skills and relies on efficient training. And we have to communicate on sepsis with relatives. S for source control is critical. Any delay, source control if feasible is associated with impaired outcomes. So be really sure of your source control in your patient in the first 6 hours. Trauma, I will fly on that, but trauma is another inflammatory state which has a lot of characteristics with sepsis, and that's really a good example and a good model for sepsis, like the use of whole body CT scan. Like ultrasound, and I think that ultrasound are really the fifth pillar of the clinical examination today, and they should be used largely in ICU for the source identification and for the organ dysfunction to evaluate each organ. That's really convenient at the bedside. V for vasopressors. You all know that norepinephrine should be the first choice, that vasopressin is today probably the best choice as second line, that other vasopressors are emerging, and that probably we need to use a multimodal approach with those drugs. Dual use for withholding and withdrawal of life-sustaining therapy, that's very important for me, that resuscitation should not be an end in itself, that the quality of life after ICU should always be discussed with the patient and with the relative, and that we should keep that in mind, and especially in those patients, sometimes I'm embarrassed with their outcomes. X for Xigris, in fact, which was a promising drug with anticoagulant and anti-inflammatory properties. Unfortunately, that don't work in several RCTs. Y for yeast. Yeast are the second agent of infection, Candida and Aspergillus. And I think that all the management about yeast are really complex, and we need something very simple to determine the best antifungal agent we need to choose at the bedside. And Z for zero and respiratory pressures, which is never indicated in our mechanically ventilated patient. But the first goal with ventilator setting is not to harm the patient. So we need to have a very personalized approach and not a kind of protocolized approach, and that's really important. So thank you for your attention. That was my personal choice. Think about your personal choice, and I'm ready to respond to your questions.
Thank you very much, Marc. It's difficult to disagree with all these points. Of course, it took some time, but you know there are 26 letters in the alphabet, right? So we will try to come back to it at the end. But now it's time to move on. So I will invite Andreas Edel, who is consultant at the Charité in Berlin, to discuss the phenotypes, a very important topic and very timely topic. So Andreas, please go ahead.
Okay, thank you. I will, as you already said, focus on the phenotype sepsis. I hope you can see my presentation. Took a little bit time. Now, okay.
Yeah, absolutely.
And
go ahead.
yeah, okay. I have no conflict of interest, and I will move quickly on to the main topic I want to discuss and ask myself, okay, how can machine learning help our daily life in the ICU, and which kind of phenotype do we have, and how can machine learning improve our understanding? And that's why I found this really interesting paper from our colleagues from Pittsburgh, from Seymour, which wanted to analyze a big cohort with machine learning algorithm, and look which kind of results they could find. And first of all, I want to show you the huge cohort they had. They had a retrospective cohort with a derivation and validation, where they tried to analyze this septic patient and wanted to find the best clusters of phenotypes of sepsis. And then they got additional cohort study, additional information to find a difference of biomarkers, and this is one of the cohort studies they used. And also they used randomized clinical trials, so big trials in the past. And we will focus later on this trial, the protocol-based care of early septic shock, so a randomized clinical trial who wanted to analyze the impact of early goal therapy versus normal therapy. But go a little bit back. What they did to analyze the different phenotypes, they selected 29 variables out of the routine data set of those trials, of those retrospective trial. And one of them was the demographic variables, so age, sex, comorbidities. The other one was out of the records, so the vital signs, the blood pressure, temperature, but also lab values from markers of inflammations, but also organ dysfunction markers out of the lab. And all those variables were put together to a machine learning algorithm, to a cluster analyzing, and then they found that there are four phenotypes who fit best the models. And actually those four phenotypes we also find in our ICU. So we have alpha phenotype, so the phenotype of patient with less organ dysfunction, of less lab values who are severe different from the normal value. We have a phenotype of older patient with more chronic diseases. We have a phenotype, the gamma phenotype, with more inflammation markers. And then we have a huge group of delta phenotype with increased serum lactate level, hypertension, elevated transaminase. So those patients have a severe kind of sepsis, and it's also the biggest group in this study.
And Andreas, I'm afraid you will have to move a little faster because we won't have time for discussion here. You know, this is only one approach of phenotypes, but there are many others. Yeah.
No, I already, though this is the phenotypes, and the phenotypes have also a different kind of correlation of biomarkers. So we have pro-inflammation and anti-inflammation biomarkers, and those are represented here. So we see a different pattern in those phenotypes. And what is and this is really important for the impact for further studies and for our approach in the ICU, is how could actually change those phenotypes distribution in further studies. And I will show you here what happens if the phenotypes distribution is changing. They actually change the amount of patients of the phenotypes. And what you can see that in this study, which was that had no different outcome of the study changed, so that the increase of phenotype 1 alpha patients, or younger patient with less severe, did even benefit from the early goal approach. But on the other hand, if you increase the delta distribution, then you can see there's even a harm. So this just shows, okay, we have to look our phenotypes, and then we have to reorganize our studies. And another interesting study was from Weill et al., which wanted to show, okay, what kind of data dynamic treatment regime modeling can influence the treatment. So it's pretty much the same model design, but what they did, they analyzed the actual and the optimal strategy for treatment, and they focused on fluid intake and norepinephrine intake. And what you can see that the optimal and the actual treatment was different between the groups. And especially if you have a kidney injury, you see, okay, the optimal would be a little more fluid intake and a little bit more increasing dosage of the norepinephrine. So to sum it up, yeah, it is possible to phenotyping with clinical data. So the phenotypes can have impact of the further randomized trials. And the interesting question would be, which impact would those phenotypes have for the further ICU treatment? And I hope I didn't spend so much time, and thank you very much.
Thank you very much indeed, but you could consider other phenotypes. What about a more coagulopathic phenotype? What about an immunosuppressed phenotype? What about the hyperinflammatory? What about, I mean, there are a number of phenotypes that could be identified, and perhaps this could lead to biomarker guided therapies, right? Is it what you think? You're muted.
Yes, sure. Sure. It's one point. Though there are different models, and this is just one example what I showed here to like the machine learning out of routine data. So that's, I think, is really important. So that's the future there, that we just calculate out of like the computer on bedside, what could be the best therapy on routine data. And what you said is also really interesting, but I think it's not like out of the routine data, though we have to get further studies to look at biomarkers, which can provide a better idea of phenotypes, and even on the transcriptome level or in the genic level, to improve our therapy.
Yeah, I think that's very thoughtful indeed. There is a lot to do. It's very exciting, actually. That brings us into the future. Let's keep our next questions for the discussion section, and let's invite Vitaly Herasevich to discuss the sepsis surveillance. It's also a very important question, of course. So, Vitaly, please.
Hello, everyone. Share my slides. I have some conflict interest to disclose. We researched this for 15 years and may hold patent on the sepsis monitoring technology, which was licensed to company Ambient Clinical Analytics, and they have FDA cleared product on the market. But we are doing this like research for past 15 years, and so it's good. All this started like way back, and back to 2008, we published first report on the sepsis screening and surveillance. We did 2 months prospective implementation in a MICU, found some moderate sensitivity specificity, and really learned what there would be no magic with computers, and we really need to study this further. But why we do this sepsis surveillance, sepsis alerts? Because every hour matters, and really, if we can detect sepsis early, we can apply most best evidence care to these patients, which improve surveillance of them. Okay, let's do alert. That looks like an easy task. What is the alert? What is the definition? And alert is automatic warning, which actually results from measurement to indicate relevant deviation from normal stage. Something go off, we go alert. Why we do alerts? Because that's already proved and evident what alarms improve patient safety and quality of the care. And final goal of the alarms could be to detect changes as early as we can and suggest appropriate action, decision support system on the top of that. And people doing this sepsis surveillance since then, many publications, systematic reviews or so. But this is 2011 report, which that was prospective trial, one of the not many prospective trial at that time. They got, again, moderate sensitivity, specificity, but what they learned, and that's important, what all this strategy was following to detect severity, detect sepsis cases before caregivers. They sent alerts, but they was so late, you know, people already know about it. And of course, with the era of machine learning and this AI, everybody tried to do machine learning algorithm applied with different techniques. For example, this is a report from 2019 when random forest machine learning algorithm was applied for a cohort of the patient. And algorithm demonstrates sensitivity of 26%, which very low, but again, that could be tuned up. It's not an issue here. But what was important, there was no significant difference in mortality or discharge disposition on transfer to ICU and any reduction in quality metrics. This is motto from Silicon Valley: move fast, break things. And Epic EMR vendor did on Epic sepsis sniffer, which used some machine learning algorithm, it's close algorithm. And again, result of this study will show what alert is pretty noisy. And they sent a lot alerts for patients they're not supposed to send. And they also did not identify 67% of the real septic patient, and create 18% of the all patients they receive alert, which create large burden of the alert fatigue. That was publicized in many different news outlets and lead some number of the discussion. But what would be interesting, that was not related to sepsis review, systematic review, which show no performance benefit of machine learning over logistic regression for clinical prediction models. If you take data out of the MR, apply something, and we can do this as good as logistic regression. What we learned over these years, then like item number one, EMR data. Really, the data need to be reliable, and not everything captured in EMR. We assume what everything captured in EMR timely and so, but the problem is when we try to create alert, we use some historical data, and with this historical data, we don't count for this temporary relationship between data points and so. That's number one. Second, most of these reports, they testing testing diagnostic performance, sensitivity, specificity, and so. Very few testing and report usefulness of alert, how this change outcome, how this change decision making or so. Diagnostic performance is just part of the story and not most important in this situation. Pre-test probability, that's another issue. Alerting about something that providers already know. We develop beautiful alert on the historical data set. And when we apply this prospectively with all this data delays, with all approach when clinicians do job and then document it, we get alert, beautiful alert on the something what clinicians already know, and notify them as the something which will be late. Prediction lead time and risk benefit analysis, not so much done on that. Again, this is like with the Epic EMR example, the system not predict really, that's more detection rather than prediction. And with all this burden, then no risk benefit analysis done for that. And of course, alerts for non-actionable events. I did not see so much papers when they take into account patients who, for example, do not resuscitate status, and still these systems, they detect and alert this type of the patient. All right, how we go forward with that? Number one, failure to rescue alert. We need to acknowledge what no perfect detection algorithm exists, and no way to make it, and no needs to do this. But we really need to take into account many different aspects of alerts, and send alert, detect only patient who really need it. Then second, ambient data queues. We need to pump more data, ambient data into these models. AI, machine learning is not magic ball. we cannot do this out of the EMR data alone. We need to have sensors, we need to computer vision and all kind of the stuff around this data. Of course, physiological waveforms is important. Real-time data needed for all these detection systems, because EMR data usually validated data, somebody charted and that's late. Alert delivery, important. Decision support system need to something back to clinicians to encourage them use this type of the systems, not just send this alert, but give something them to want to use it. Usability is important for all these alerts. And control tower concept with a shift to virtual care and more EICU type of the care, mass surveillance, kind of the easy to implement. We can do some like single person EICU type mass surveillance of the multiple patients at the single location, and manual alert confirmation is the key. This is feedback loop which sometimes lost in all this stuff. Okay, that's my last slide.
Thank you very much, Vitaly. I think it was a very nice overview of the topic, where we are and where we are going to. And indeed, as you say, artificial intelligence will help us to look at the time course and the trajectory of patients, and that is so important. And we will return to the dynamic evaluation of all this in just a moment. Because we have about 10 minutes for discussion now, we are happy to see that there are close to 350 participants, and with many, many questions, and we won't be able to address all of them. Of course, this is not a symposium on sepsis, it's just an illustration, a discussion about the articles that appeared in ICU Management and Practice. So please go and look at the articles in our publication, and from there you may perhaps contact the speakers today to get more information. Now there are many questions in particular about antibiotic therapy. So I will first go then to the second talk, Marc Leone. Your alphabet is very nice, it's quite comprehensive, but so what? What can we do with it? Is it something that I should know at the bedside, and when we make rounds together, I will say, oh yeah, I checked A and B and C and D, blah, 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 up to Z, or what should I do with it?
No, I don't think that's kind of checklist, but I think that's a comprehensive view of sepsis, and to summarize which is the most important point for you, and where you can progress. And I think you can see the alphabet like this, a comprehensive view, how I can understand the sepsis, how can I progress in the management of my patients, and looking for the most important word, because I think that words are important in the lexicon of sepsis. And like this, perhaps we can progress, and this makes it possible to rely on your clinical experience and not only data, systematic review, and all these things that I like also.
You asked whether qSOFA is really very useful, and personally, I was part of the consensus group. I'm not fond of qSOFA at all, because it's not very specific for sepsis. It's just, you know, a bit of hypotension, a bit of tachypnea, a bit of altered mental status. That could be any form of impending shock. It could be severe heart failure, could be hypovolemia, it could be severe pulmonary embolism. So we should look at it as an alarm signal, basically. I'm wondering what Vitaly thinks about it. Do you think that the qSOFA is something useful or useless?
Well, that's important part of this evaluation, but really it's not full answer to that. Until we have something better, this is probably one of the best easy tool to use.
Yeah, absolutely. Now, someone in the audience asks, what about the role of nurses? A good nurse should be able to identify early sepsis, right? Can we rely on people, or are the system you are working on much more efficient, Vitaly?
Okay, that's like bring very interesting question regarding computer vision technology, which would play significant role in a future detection of abnormalities, not only sepsis. Yeah, that's a good technology could see patient 24/7 and detect abnormality in a patient, how patient behave and so on, and that can play a role like similar to nurse observation and so on. That's where AI and technology could shine.
Precisely this question of trajectory, Andreas, someone asks you, when we speak about phenotypes, should we take time more into consideration? Because a patient may go quite quickly from one phenotype to another, from a hyperinflammatory phenotype to some degree of immunosuppression, requiring some immunostimulation, etc. What about the time?
I think the time is really crucial. Yeah. So what we see in the ICU is exactly what you said, that we have patients with different phenotypes, but we treat them all the same. Yeah, pretty much the same. So our guideline doesn't look at the phenotypes of different phenotypes of sepsis. So I think this is a major problem. And the other thing is we actually don't know when is the time change. When does the patient change from one phenotype to another? Yeah, if you look retrospectively, sometimes we see it, but at the most of the time we can actually don't see the break point of this different phenotypes, and what kind of treatment we are change is another question. We don't know yet.
Marc Leone, should infectious disease specialists be called whenever someone has a suspicion of infection on the floor?
Well, I think, to me, infectious diseases in the ICU is part of ICU medicine. And I think that there are most instances that we can handle without an outside consultant. I think there are some very special situations where it's very good to collaborate with our infectious disease colleagues. I think for patients who are having infection that's not responding to therapy, we need other ideas. But I think the common situations where I like to collaborate are when there's concerns about infectious endocarditis, when there's concerns about meningitis and brain abscess and CNS infections. There, I think collaborative approach is very useful. But I think for some of the common infections, we can certainly start therapy ourselves, and if patients are responding and we follow the prescribed approach, I think we can usually handle that on our own. But I do think that there are instances where collaboration is very valuable, and we have to be open-minded to that.
Yeah, because Vitaly, some people have recommended to use the SIRS criteria to identify the patients who may be septic. The problem with the SIRS criteria are that it's just fever and associated tachycardia. So these are signs of infection. So someone is asking, isn't there a risk that we are called too often for too many patients, especially the rapid response systems? Maybe they would be called for any patients having 38.5 degrees of temperature. So how can we filter to react when it's necessary, but allow the doctors on the floor to act when they can manage?
Yeah, that's a very good question. And yeah, that was study in emergency department when SIRS criteria was checked on all patients who who visit emergency department. 70% of our all patient in emergency, they meet SIRS criteria at some point of this visit. And yes, that's a problem for any sepsis screening, because this is non-specific criteria or so. This is why another parameters should be added as a stop criteria for that. It's not rely only on the SIRS criteria, but have other parameters and some underlying problems and so and so and so. This is like how perfect sepsis sniffer built in.
Marc Leone, when would you like to be called on the floor for a possibly septic patient?
As soon as the diagnosis is done, I think it's important that an intensivist.
Well, but usually doctors on the floor will say the doctor doesn't, the patient does not look good. I'm concerned about the patient. So it's not necessarily that the diagnosis is already made.
Yeah. I think that as soon as there is an organ dysfunction, I want to be called, and probably if I can have a continuous monitoring on this patient, I think it's important. As soon as there is the onset of an organ dysfunction, I would say.
All right. As I said, Mike, there are several questions on antibiotics, but we have no time to give full lectures on all these aspects. But very quickly, continuous infusion of beta-lactams, always, sometimes, never?
I think sometimes. And again, it's not only continuous, but prolonged infusions are as effective.
I should have said prolonged. Yeah, the right. Person says prolonged continuous.
Right. But it doesn't always have to be continuous. It can be prolonged. And I think that the real advantage of prolonged infusion is that you have to understand that it allows you to stay above a specific MIC for a longer duration. So
yeah, sure.
there are two situations where you can do it. Sometimes when you have a highly susceptible pathogen, you can do a prolonged infusion and use less antibiotic. So it's somewhat cost saving. But I think the real advantage in the ICU is when you have a borderline elevated MIC, a borderline resistant pathogen that you don't have an ideal therapy for, you can take a currently available drug, give it as a prolonged infusion, and be above an MIC target for a longer time period. And there are some studies that show improved outcome with prolonged infusion. But again, it's hard to prove that across the board. So I think it has to be used, either it's your policy and you do it all the time, but if you don't do it all the time, you have to know about it as an option for very specific situations.
As you know, I fully agree with what you said, but as you know, there is a large clinical trial ongoing with the Australians, of course, thousands of patients with prolonged infusion versus no prolonged infusion. I think it doesn't make sense. Your answer makes sense. You need to individualize these decisions, right?
I think so. I think there are a lot of different ways to treat infection, but if you have a sensitive pathogen, you don't need a very complicated way to do it. And of course, the problem with prolonged infusions is you create a need for more lines, more ports, you're tying up ports for a longer time period. So I don't think it's practical to do it in everybody all the time.
Sure. Last question, comment from the other panelists?
I have a question for everybody, and that is, do you think there will ever be a day where we could take the phenotype, the early warning, the demographics, and be given a specific choice of antibiotics for a patient to be given quicker? Is that day ever going to be possible?
Andreas?
I hope so.
The answer is I hope so.
Good.
That would be great, yeah, just to have like individualized therapy for each patient of ICU, because lots of things we don't know. So we don't know how they metabolize the antibiotics, what is the actually distribution volume of the patient, yeah, all the things we don't know, and we have to now just decide from every patient without knowing what's the best way of treatment. Yeah.
Yeah, that's very close, but it's not there. And with current understanding of the syndrome, that's probably impossible to do right now. But again, that's like all these pieces coming nicely in the near future together.
And some microorganisms may smell. Perhaps we need artificial noise, you know, to smell the Pseudomonas. No?
Yeah, as you know, there are studies of ventilator-associated pneumonia using an artificial nose to identify VAP early, and it correlates as well as clinical detection. And that may be a very good way. I mean, I can imagine the day coming when I walk in the ICU and the nurse says to me, the nose says the patient has pneumonia and it's Pseudomonas and we have to start therapy. And that may very well be something in the near future.
Do we all agree? If so, I think it's time to bring it to an end. So I would like to thank you all, again, referring to the publications in ICU Management and Practice. And I think we had a very interesting discussion. Many, many thanks to all of you.
Bye-bye, everybody. Thank you.
Bye-bye.
Thank you. Bye-bye.
Thank you.